Hello, this is Lauren Sheely. I am going to be presenting my clinical project, which was looking at on-demand therapy with proton pump inhibitors in non-erosive reflux disease. So this is a strategy for managing reflux symptoms while reducing PPI use. So on-demand therapy is basically an as-needed dose of PPI. And this was a topic of interest for me because of the frequency that we see reflux disease in family practice. And while reading through a management guideline for GERD, I saw on-demand dosing recommended for PPI therapy in patients with mild or non-erosive disease. And that's something that I had never seen in practice. And I find that patients are often reluctant, or it's difficult to taper them off of PPIs. So I wanted to look a little more deeply into this topic and find out about the evidence behind it and find out if it really is an effective approach to management. So in my reading, I found that about 60% of patients with GERD have no evidence of inflammation or erosion on endoscopic exam, yet they often have recurrent symptoms, often for years. So this is classified as non-erosive reflux disease, and it's very rare for these patients to progress towards having erosive disease or Barrett's esophagus. So the goal of treatment in these patients is just to manage symptoms, not to prevent Barrett's esophagus or anything like that. Research has also found that PPIs are overused, both overprescribed and overused as over-the-counter medications. They're often used for long-term, indefinite, or lifetime use, even with patients who have mild, intermittent, non-erosive disease. And PPIs are associated with a risk of dementia, vitamin B12 deficiency, bone fracture, C. diff infection, pneumonia, and in some subpopulations, an increased risk of cardiac events and iron deficiency. So as with any medication, you don't want to give a higher dose or an unnecessary medication if you don't need to. So my question was, in patients with non-erosive reflux disease, is on-demand therapy with PPIs effective for long-term management of symptoms? And within this is the fact that on-demand therapy does reduce the actual amount of medication that the patient is getting. So that's not written into the question, but that was part of my consideration. So in order to investigate this question, I read one systematic review and 5 RCTs. The systematic review looked at 17 RCTs that evaluated the efficacy of on-demand therapy. 3 of the RCTs that I read compared on-demand PPI therapy to placebo, and 2 of them compared on-demand PPI therapy to continuous daily dosing of PPI. So overall, these were level 1 to 2, moderate to high quality articles. There was one RCT that was of lower quality because of a smaller sample size of 150 or so and unknown statistical power. However, overall, the studies were higher quality, high level evidence, and their findings were consistent. So overall, the evidence found that on-demand therapy reduces exposure to PPI medication. Patients take about 1 capsule out of every 3 to 4 days with on-demand therapy, or 1 to 3 capsules per week. And on-demand therapy was found to effectively control symptoms, even though it doesn't prevent symptoms, and to improve quality of life and maintain it at a level comparable to the general public, and also to maintain patient satisfaction at a level that is comparable to patients who take a PPI on a daily, everyday basis, as well as in comparison to placebo. So my clinical project was to create a 1-page teaching tool for providers. A couple of providers that I spoke to in family practice were unfamiliar with the term on-demand dosing. They didn't use PPIs or recommend or prescribe them as needed medications. And also I feel that a lot of patients in family practice are reluctant to taper or discontinue PPIs. So the aim of this tool was to guide both practice as well as patient teaching when patient teaching needs a little reinforcement to fill in what the evidence really shows. So my teaching tool included an outline of the problem and a brief summary of the evidence that I found that supports on-demand therapy. It included dosing guidance and contraindications for patients who it would not be appropriate to use on-demand therapy with. So this was a handout that I presented also with a brief presentation with a PowerPoint. And generally it was well received, but with lots of questions and some doubts and skepticism based on providers' clinical experience. So even though I got all 5s on my numeric rating score, I felt that providers were a little bit skeptical. So based on some of the questions that I got, I concluded that my question itself was sort of a barrier to this being a successful clinical project, because managing GERD involves a lot more than just dosing PPIs, and providers have a lot of experience trying to taper PPIs in patients who, if they even skip one day, they have reflux symptoms, and it's a really challenging, frustrating thing for a lot of providers. So I'm not sure if maybe making a patient-oriented teaching tool would be more helpful. That was one of my original ideas, but then finding a couple of providers who were not familiar with on-demand dosing, I felt I would start with the providers first. So I'm not sure, maybe a patient-oriented teaching tool could encourage some patients to try on-demand therapy once they see the evidence that studies show it's actually effective, or if they read the evidence shows that the drugs are associated with adverse effects. I'm not sure. And the other barrier that I felt came up in provider questions was that my PIO question was basically very, very narrow. So I eliminated other relevant concerns, such as what are the statistics about the adverse effects, like what's the actual risk of developing dementia when you're on a PPI. I didn't look at how using on-demand therapy affects your other management of reflux symptoms, such as should you continue doing follow-up endoscopies. So I got a lot of questions from providers that I really didn't have answers to. And another question that I got was, how does this strategy compare to tapering PPI altogether and using an H2 blocker instead? And I really had no idea. So I feel like this is a really broad issue, managing GERD in family practice. And my project was very specific to, is this dosing strategy an effective way to approach these patients who have non-erosive disease? And I felt that the answer was yes. And so as far as delivering that information to providers, I felt that that was effective, and they received it well and, appreciated that consideration and said that they might consider it with appropriate patients in the future. But I feel like there are a lot of other things that could be included in a broader project to kind of reinforce the reason. And I think that a lot of providers continue to think that PPIs are relatively safe, and without having the actual numbers saying, this is the actual risk of developing dementia when you take a PPI, they weren't completely convinced, I would say. So considering what I might change in the future, like I said, expanding the discussion of the risks and the adverse effects. People like numbers, so statistics, numbers needed to treat, etc. And the fact that the causation of dementia, for example, related to PPIs has not really been clear. That relationship hasn't been clarified by research yet. So there was some skepticism as well because, what is that association with dementia? Is it really related to some confounding factor that we haven't identified yet? And then the other things that could be changed in the future would be considering other recommendations related to management of non-erosive reflux disease, which again would be expanding my overall question, but for example, how frequently to follow up with endoscopy, how effective PPIs on demand are compared to H2 blockers, etc. And then as far as evaluation, I think this is partly just based on providers' experience in clinical practice and if they are using the tool, if they could report back that they're referring to this teaching tool, that would show that it was being, effective. And then the other thing I was considering was with the actual presentation that I gave, it would be interesting to start that presentation by polling the providers about what their experience with on-demand therapy was already. So I knew that 2 of them had never heard of it before, but I would be interested, based on how skeptical they were, have they tried it and it's failed? Have they read about it? Have they read conflicting research to what I found? So for the providers who seemed quite doubtful, I think it could be helpful moving forward to dive into what that doubt is based on a little more, and why, even though I'm presenting this high quality evidence that shows that this can be a really effective strategy for patients, some providers are still kind of like, well, I don't think PPIs are that harmful, and it's really hard to try to get people to cut back on PPIs, so I'm skeptical. So anyway, this was a great learning experience, and I think there are definitely ways that the project could be expanded upon. I think that would have made it into a much bigger scope of a project compared to a one-semester clinical project, but there are definitely a lot of different directions that research and clinical projects could go with this topic of managing reflux disease and looking at PPIs and the adverse effects that are associated with them. So yeah, there are a lot of different directions that this could go. So I guess that's it. Please let me know if you have any questions, and I would also love to hear about any of your experiences in clinical, if you have come across on-demand dosing, if your preceptors have used it or mentioned it or been frustrated by it or anything like that. I would love to hear your experience. Thanks.